Dengue fever. Dengue is the most rapidly spreading mosquito-borne viral disease of mankind, with a 30-fold increase in global incidence over the last 5 decades. 390 million dengue infections per year worldwide, of which 96 million manifest clinically. The number of cases reported increased from 2.2 million in 2010 to over 3.34 million in 2016. Dengue infection is caused by dengue virus, which is a mosquito-borne flavivirus. It is transmitted by Aedes aegypti and Aedes albopictus. There are 4 distinct serotypes: Dengue 1, 2, 3 and 4. Each episode of infection induces a lifelong protective immunity to the homologous serotype, but confers only partial and transient protection against other serotypes. The incubation period for dengue infection is 4 to 7 days. After the incubation period, the illness begins abruptly and will be followed by 3 phases: febrile phase, critical phase, recovery phase. The onset of dengue fever is usually with sudden rise in temperature, which may be basic, lasting 2 to 7 days and commonly associated with headache, flushing and rash. There may be pain in retroorbital area, muscles, joint or bone. Rash may be maculopapular or rubelliform and usually appear after 3 or 4 days of fever and commonly seen in face, neck and other part of the body. Localized cluster of petechiae may appear over upper and lower limbs. Dengue fever patients usually go to critical phase after 3 to 4 days of onset of fever. During this critical phase, plasma leakage and high heme concentration are documented and patients may develop hypertension. Abnormal hemostasis and leakage of plasma leads to shock, bleeding, accumulation of fluid in pleural and abdominal cavity. The period of plasma leakage usually persists for 36 to 48 hours. During the recovery phase, the extracellular fluid which was lost due to capillary leakage returns to the circulatory system and signs and symptoms improve. This phase usually after 6 to 7 days of fever and lasts for 2 to 3 days. Longer convalescence may be expected in some of the patients with severe shock, organ involvement and other complications which may require specific treatment. Patient may develop pulmonary edema due to fluid overload if the fluid replacement is not optimized carefully. Dengue fever is characterized by fever of 2 to 7 days with 2 or more of following: headache, retroorbital pain, myalgia, arthralgia with or without leukopenia, thrombocytopenia and no evidence of plasma leakage. Dengue hemorrhagic fever 1 is characterized by above criteria plus positive tourniquet test and evidence of plasma leakage. Thrombocytopenia with platelet count less than 100,000 per cubic millimeter and hematocrit rise more than 20% over baseline. Dengue hemorrhagic fever 2 is characterized by DHF1 plus some evidence of spontaneous bleeding in skin or other organs, black tarry stool, epistaxis, gum bleeds, and abdominal pain. Thrombocytopenia with platelet count less than 100,000 per cubic millimeter and hematocrit rise more than 20% over baseline. Dengue hemorrhagic fever 3 is characterized by DHF2 plus circulatory failure, manifesting as weak rapid pulse, narrow pulse pressure less than 20 mm Hg, hypertension, cold clammy skin, restlessness. Thrombocytopenia with platelet count less than 100,000 per cubic millimeter and hematocrit rise more than 20% over baseline. Dengue hemorrhagic fever 3 or dengue shock syndrome is characterized by profound shock with undetectable blood pressure or pulse. Thrombocytopenia with platelet count less than 100,000 per cubic millimeter and hematocrit rise more than 20% over baseline. In diagnostic tests for dengue fever may include ELISA-based NS1 antigen tests, IgM capture enzyme-linked immunosorbent assay, isolation of dengue virus, polymerase chain reaction, IgG ELISA, and rapid diagnostic tests. The clinical presentation of dengue fever is similar to many other conditions. Paracetamol every 6 hours may help to keep the temperature below 39 degrees Celsius. However, aspirin and brufen should be avoided. Bed rest and adequate oral fluids are advised. Oral rehydration solution, ORS, such as those used for the treatment of diarrheal diseases and/or fruit juices, are preferred to plain water. Intravenous fluid may be administered if the patient is vomiting persistently or refusing to feed. Close monitoring for the initial signs of shock is needed to prevent complications. Close monitoring of hematocrit should be done until the temperature remains normal for 1 or 2 days. Any person who has dengue fever with thrombocytopenia, high heme concentration and presence with abdominal pain, black tarry stools, epistaxis, bleeding from the gums, etc., needs to be hospitalized. All these patients should be observed for signs of shock. Rise of heme concentration indicates plasma leakage and loss of volume, for which proper fluid management plays an important role. Oral rehydration should be given along with antipyretics like paracetamol, sponging, etc. Immediately after hospitalization, the hematocrit, platelet count and vital signs should be examined to assess the patient's condition, and intravenous fluid therapy should be started. If the patient has already received about 1000 milliliters of intravenous fluid, it should be changed to colloidal solution, preferably dextran 40, or if hematocrit further decreases, fresh whole blood transfusion 10 to 20 milliliter per kilogram per dose should be given. In case of persistent shock even after initial fluid replacement and resuscitation with plasma or plasma expanders, the hematocrit continues to decline. Internal bleeding should be suspected. Oxygen should be given to all patients in shock. Any patient with dengue fever should be closely monitored for the warning signs. The preventive measures for dengue include preventing mosquitoes from accessing egg-laying habitats by environmental management and modification, disposing of solid waste properly and removing artificial man-made habitats, covering, emptying and cleaning of domestic water storage containers on a weekly basis, and applying appropriate insecticides to water storage outdoor containers. Personal household protection measures include using window screens, wearing long-sleeved clothes, using repellents and insecticide-treated materials, and using coils and vaporizers. These measures have to be observed during the day, both at home and place of work, since the mosquito bites during the day.